everybody. My name is Kristen Hammergren, and I would like to thank you all for joining us for the Chordata Oncology webinar series. Today's webinar features speaker Dr. Kevin Hughes, and he will be going over cancer risk assessment, the why and how for affected and unaffected patients. Dr. Hughes is actively involved in the establishment of standards and in research regarding the genetics, screening, diagnosis, and treatment of breast cancer. He is an active breast surgeon as well as co-director of the Avon Comprehensive Breast Evaluation Center at the Massachusetts General Hospital. And he's also well known for his development of the Hughes Risk app. Dr. Hughes will be answering your questions that were submitted with your registrations, as well as any that come in during your presentation. So to submit any questions, use the question box in your GoToWebinar panel, which is located on the right-hand side of your screen. And with that, I'm going to go ahead and hand things over to Dr. Hughes.
Well, Kristen, thank you very much, and thanks to Chordata for making this possible. So as Kristen had mentioned, I'll be talking about cancer risk assessment, the why and how for affected and unaffected patients. We obviously will not cover all of risk assessment in the next hour, but let's talk about some of the interesting aspects of risk assessment, how it's changing, and how we might make it more efficient or more effective for our patients. In terms of the why of risk assessment, the reason we do this is to identify patients at high risk and then make available to them management strategies that can either prevent cancer or find cancer earlier. Obviously, genetic testing is high in the area in terms of things that we can do for these patients to be able to identify a patient with a mutation. To identify patients who may need prophylactic oophorectomy, removal of the ovary to prevent ovarian cancer, but also to decrease the risk of breast cancer. Patients who need chemoprevention, tamoxifen, raloxifene, exemestane, drugs that can drop breast cancer risk. Identifying what patients require prophylactic mastectomy to prevent cancer, or those who choose follow-up, which ones need MRI, which ones need mammography, and when those studies should begin. So all of these are things that we can do for our patients who are at elevated risk. And the problem is that if we don't identify these high-risk individuals, we'll have unnecessary morbidity and death, essentially, that could have been prevented had we known they were at elevated risk prior to their developing disease. All of you are very familiar with BRCA1 and BRCA2. The risk of breast cancer in a female with a BRCA1 or 2 mutation is quite high, anywhere from 50 to 87% in their lifetime. Ovarian cancer risk for BRCA1 is higher than for BRCA2, but both are massively increased above the general population, where the risk is about 1.4%. Male breast cancer can occur, certainly with BRCA2 mutations, at a extremely high rate for males, so still a low rate compared to females. But most importantly, males can pass along this mutation as well as to their daughters as well as females can. And because of this, we need to look at paternal family history as well as maternal family history. To get a sense of what we're looking at here, when we look at hereditary cancers in general versus sporadic cancers in general, a good thing to think about is Knudson's two-hit hypothesis. At the top of the screen, we look at sporadic cancer that can occur in women who don't have genetic mutations. When we think about the genes like BRCA1 or BRCA2 or other genes that cause colon cancer, melanoma, etc., we think of them as tumor suppressor genes. And in the patient who does not have a hereditary syndrome, every cell in the body has 2 normal sets of chromosomes and therefore 2 sets of tumor suppressor genes. When one chromosome loses a tumor suppressor gene, the other chromosome still does the backup work necessary. But when that cell develops a second hit, the second tumor suppressor gene is inactivated, the person goes on to cancer development. Well, in the sporadic cancers, this occurs relatively late in life and occurs relatively infrequently and seldom occurs in large numbers in the same family, because it's an uncommon event to have both of these hits occur in the same cell. With hereditary cancers, everybody is born, every cell in the body is born at birth with a single hit already. If any of those cells pick up the second hit, that cell can then go on to further mutation accumulation and go on to cancer development. So the hallmarks of hereditary cancer are that it occurs early in life, more likely in the 20s or 30s than the average age of breast cancer being in the 60s. It tends to occur in multiple organs, bilateral breast cancer or breast plus ovarian cancer. It tends to occur often in a single family, and it tends to occur in unusual locations, such as male breast cancer. So by thinking of this as a tumor suppressor gene, in thinking of Knudson's two-hit hypothesis, we can kind of understand in general how hereditary cancer syndromes occur and why they look the way they do. Now, we've been doing BRCA testing for about 18 years. We would estimate that there are about 560,000 to 720,000 mutation carriers in the United States. And despite having done this for 18 years, we found about maybe 70,000 of those carriers, but most of the carriers we've identified already have cancer. So what that means is that about 95% of the unaffected carriers, of women who do not yet have cancer, remain unaware that they're mutation carriers and therefore remain mismanaged or not getting the proper screening, follow-up, prophylactic surgery, preventive measures, etc. So BRCA is about the best we're doing of any adult hereditary syndrome. We're doing very poorly. And the reason we're doing so poorly is that it's hard to identify these patients. It's hard to get them in for genetic testing. It's hard to get them to the right professionals who can then take care of them. And this is a problem that we really need to solve, not just for BRCA1 and 2, but for all hereditary syndromes, especially adult, as we're talking about today, but then pediatric as well. Now, after 18 years of this, after not doing BRCA1 and 2 nearly as well as we should have been doing, we're now suddenly faced with a lot more genes that can cause breast cancer, some of which are relatively new to us. But genetic testing is now becoming routine, not just for BRCA1 or 2, but for P53, for P10, for Cowden syndrome, for Putz-Jaeger syndrome, etc. So now, in addition to just knowing about BRCA1 and 2, which most of us have gotten pretty comfortable with, we now have to know about all these other possible breast cancer genes as well, and also get a sense of what these other genes do in terms of syndromes, some of which are relatively new and uncommon and don't even have a syndrome name as of yet. In a study by Nadine Tung from the Beth Israel Hospital, she looked at 1,781 hereditary breast ovarian cancer-like patients. She did the 25-gene panel from Myriad Genetics. You'd get similar results with any of the gene panels that are out there, but this was a study done with Myriad's panel, and they found that of the patients who looked like they were high risk, about 13.5% had a mutation. Only 2/3 of those, about 9.3%, were BRCA1 or 2. The rest were in other genes. And of interest, in these other genes included patients who had actually colon cancer syndromes. And it's not necessarily that the breast cancer family history was what identified these colon cancer syndromes. Those colon cancer syndromes may have been there and not even recognized because they had not yet manifested themselves in a strong family history. So as we move towards panel testing, we're going to be identifying other genes we hadn't really thought about beyond BRCA1 and 2, and sometimes identifying genes incidentally that may not even be related to the family history we were originally looking at, the breast ovarian family history perhaps. Now, as well as for breast, ovarian cancer now also has another set of genes to think about, getting beyond BRCA1 or 2. We know also the Lynch syndrome genes are certainly important for ovary, but also TP53, STK11, etc. also can increase risk for ovarian cancer. So as we're doing our testing, it's not just looking for breast, ovarian, BRCA1 and 2, but looking for all the genes that may be causing these syndromes. Mary Claire King and her group at the University of Washington also did a panel test using a different gene panel. This one was looking at a 21 gene panel for ovarian mutations. And they found that there were 12 different genes that were identified in these strong ovarian cancer families. Only 18% were from BRCA1 or 2, 6% from other genes. 30% of these carriers had no strong family history, and 35% were over 60 years old. So some of the things we've thought about in the past, only testing women who are young, only testing women with a strong family history, may not be applicable for women with ovarian cancer who all really should be tested by the NCCN guidelines. But again, beyond knowing just BRCA1 and BRCA2, we have to now start thinking about these other genes, which will come up as findings when we do our testing, but also we have to then know what do we do with these patients once we identify these other gene mutations. Now, while BRCA1 and 2, again, we have a pretty firm grip on what these genes are and what they do, as we start moving into full gene testing or gene panels, if we get back a different mutation, such as a PAL-B2 mutation, we're not going to necessarily have the same spectrum of cancers that we have with BRCA1 and 2. So we have to not keep in our mind, we've always kept in our mind BRCA1 and 2, let's say breast and ovary, think a little bit about melanoma, pancreas, think about prostate. But now, gene by gene, we're going to see different syndromes that are important, different sets of cancers that are important, different management schemes for these various cancers, for these various gene mutations. And in addition to being different spectrums of disease, we also have to look at different penetrance of these genes. This paper showed a very nice graph, and this has been reproduced elsewhere, that looks at the risk of breast cancer, relative risk of breast cancer here versus the incidence of a gene mutation in the population here. And what you look at here is that in the very low frequency genes, the very rare genes, there's extremely high risk of cancer. On the other hand, in these genes here, when there's a mutation, it's relatively common to find these mutations in the population, but there's a very minimal increase in risk of breast cancer. And then in the middle are genes that are not quite as uncommon as BRCA1 or 2, but are more common and yet less penetrant. So part of what we have to think about is not just the patient has a mutation that increases the risk of breast cancer, but the patient has a mutation that increases the risk of breast cancer by how much. And depending on how much that risk is increased, would help you then determine what type of management to do. Increased risk might generate an MRI, but it probably should not generate prophylactic surgery unless the risk is significantly elevated for that particular person with that mutation. We can't just treat all mutations the same anymore. We're starting to see real differences in how they act, what spectrum of disease they create, and how often they create disease. Now, if you think you can't keep up with all of this, don't worry about it. No one else can either. We are now getting to a point that there is so much information coming out that it's impossible for a single human being to keep track of all the information, all the syndromes, all the penetrances, all the different management strategies. So I'd like to think about this not just as it impacts genetics, but now beginning to impact all of medicine. We're getting to the point right now where the human brain is approaching its limits. There are limits to how far the human brain can go, for how much the human brain can recall, for how much it can store. And our problem currently is that while the rest of the world has begun to use computers to make humans more effective, medicine has been pretty far behind in that approach. And Crane and Raymond from Kaiser Permanente said that we continue to practice what's called memory-based medicine. And this idea that if we remember something, then it gets done. And if we don't remember, then it doesn't get done. And we have to move beyond just what our memories can help us to do. To look at this a little more clearly, think about it this way. This is a graph of the number of articles in PubMed from the 1950s. And what you can see is that the number of articles published on a yearly basis has been increasing exponentially. Now, what have we done in order to try to keep up with that? Well, let's think about medical oncology initially. Back in the 50s, medical oncology was handled by the hematologist. There were no medical oncologists at that point in time. But as more and more information began to accumulate, hematologist-oncologists became a new specialty. Hematologists became double-boarded both in hematology and in medical oncology. Over time, oncology became so much information to absorb and track that it became its own specialty. So hematologists were there, oncologists were there, and very few people are really double-board certified or continue to practice both areas completely. From there, we've moved on to breast oncologists because the medical oncologists could not manage all of oncology. They really had to start specializing in breast oncology, lung oncology, gynecologic oncology from a medical point of view, etc. And now if you think about it, we also have specialists now in triple-negative breast cancer. We have specialists in hormonal-positive breast cancer. And what we're trying to do is decrease the amount of area that any particular human being covers in order to be able to handle the volume of knowledge just in that one specific area. But I think we're getting to the point where that's going to become a losing battle. We can no longer subspecialize beyond triple-negative breast cancer or beyond hormone-positive breast cancer. It gets to the point that we have to start using other techniques beyond super specialization. For those of you in the genetics world, which are all of us on this call, these are the number of articles written on breast cancer genetics. Almost no articles in the 1990s. In 2012, over 4,300 articles just on breast cancer genetics. None of us can read all these articles. For those of us who try to do all of cancer genetics, it's overwhelming. For those of us who do just breast cancer genetics, it's relatively overwhelming. So we're getting to a point again that the amount of knowledge is beyond what one human can do. And this is the number of genetic tests available, or what number where syndromes have genetic tests available. We're now looking at over or close to 3,000 syndromes that have genetic tests associated with them, again, beyond what any single human being can manage. So I think the point here is not to say that humans aren't bright. We obviously have gotten pretty far doing what we do, but we need to find new methods to keep track of all the data and all the explosion of data beyond just our own memories. Now, probably the best way to think about what we need to do next is what's called clinical decision support. And that's applying models or guidelines to patient data to identify the best course of action. It's using a computer to take the data that's available on the individual and then take what's known about that particular problem and associate that particular patient with that particular set of management strategies to find out what the best course is for that individual. Now, next is to display those results as what's called a visualization. It's a way to display information, a large amount of information, in a relatively intuitive manner. And a pedigree is a perfect example of visualization. You're all familiar with pedigrees. You can very simply see here that the mother had ovarian cancer, the aunt had breast cancer, the patient herself had breast cancer. You can see this is a maternal pattern. You can see it looks like a Mendelian dominant pattern. But the visualization of the pedigree can help you better understand the family structure and the transmission of genetic problems or the transmission of disease through that family. You can go a step further and run a risk model like BRCA Pro and say that based on this particular family constellation, that the risk of mutation for this individual is about 25%. She's got about 1 chance in 4 of having a mutation. Well, you can then go a step further and say, well, if you got a 25% chance of having a mutation, you should consider genetic testing for this individual. So by putting data into a computer, by producing a visualization like a pedigree that makes it easy to look at that particular family structure, by running models that can then tell you the risk of mutation, and then using guidelines to identify that this person needs genetic testing, as an example, are methods of clinical decision support. It's the ability to have the computer help you do your job better, not by replacing humans, but by making them more effective in what they're trying to do. Now, this approach was actually defined back in the 1950s. So this was in the very early days of computers. at a time when computers filled up entire rooms and had barely the functionality of 1/100th of a cell phone today. But back then, people kind of understood what was coming down the pike, and they found themselves going off into two different camps. One camp was called artificial intelligence, and the idea of artificial intelligence was that the computer would replace the human. That would be smarter than the human, it would have more capability than the human, it could do everything that a human could do, so artificial intelligence would essentially take over. We're really still not there. Even with all the power of computers today, artificial intelligence remains a relatively a future effect, though certainly it will come down the pike eventually. But the alternative approach, which has been much more effective, is intelligence amplification. And what these people understood was that computers have strengths and weaknesses. Computers are extremely good at holding large stores of knowledge. They're extremely good at running very complex calculations. They're not so good at talking to a patient and eliciting a set of symptoms. So computers have a very strong ability to manage a large amount of data and large calculations. And by the same token, humans have strengths and weaknesses. We can store a fair amount of data in our minds, but nowhere near what a computer can. And we can not do complex computations in our head usually. On the other hand, we have strengths, and our strengths are that we can talk to a patient. We can see how she's reacting. We can identify whether she's worried about something. We can probe deeper where it looks like there's information that she may have, and we know intuitively that she has more information. So our ability to extract information and our ability to then feed back information in a way that people understand might be a little bit better than a computer necessarily. So the idea of intelligence amplification is humans working with computers. And as the old $6 million man saying went, we can make it better, stronger, faster. We have the technology. What we haven't done in medicine is harnessed or use that technology very effectively. So that's kind of where we want to go. So we're very accepting of this idea in the mechanical world. We know that a human can go 3 miles an hour perhaps when they're walking. A human on a bicycle might go 20 miles an hour, and then we move into the machine age where humans plus a car might go 60 miles per hour or faster, and then get into planes. God knows how fast you can go. But you're looking at, we have no problem with mechanical amplification. We have the ability for a human to use a machine and then do things faster, stronger, whatever else you might think. But all of these require the human to control the actions of the machine. Whereas when we move to computers, computers can actually control some of those actions themselves as well. So moving on to intelligence amplification, imagine that a human can talk to a patient and gather data very well. They could draw a pedigree and then eyeball that pedigree, and they could then counsel the patient. In fact, this is how much of genetic counseling is done today. But if you use a human plus a computer, the human can use what they're strong at. Talking to the patient, gathering data, collecting more information about what might be going on. Computers can run risk models and look at guidelines very effectively. Computers can draw pedigrees or other visualizations to help you understand what that data all means. And then the human can then synthesize that data back into a coherent whole as it relates to that individual patient, and then go on to counsel the patient. So this idea of intelligence amplification, of letting the human do what they're best at, letting the computer do what they're best at, and bringing that together to make the consultations more effective in terms of managing your individual patient. Now, in terms of a high-risk program, we really have two different areas we need to think about. One is, how do we identify women at high risk? And that can be done either in the breast imaging world, the primary care world, medical oncology, OB/GYN, anywhere else, where large numbers of patients are coming through for routine care. And among those patients, how do you identify those at elevated risk who would benefit from a genetic counseling or a risk assessment consultation? At the next level, once that very small subset of high-risk women is identified, very small percentage-wise, but very large when you look at the actual number of women, When you look at those people who are identified who come into a high-risk clinic or a high-risk system, we need to then manage those women. Who needs genetic testing among that group? Who needs more intensive screening? Who needs chemo prevention? And so these various aspects have to be managed, but you're looking at two specific problems to work on. One is identifying the high-risk individual, and second, once they're identified, how do you then manage them appropriately within the context of your clinic? Now, when we look at identifying high-risk individuals, we want to look at two different aspects. One is what is their risk of mutation? Do they need BRCA or other breast cancer gene testing? And second, what's their risk of developing breast cancer over time? Do they need an MRI? Do they need chemo prevention? Do they have a different or more personalized screening approach than yearly mammography after the age of 40? This is what you have to do in terms of identification. Who's at the highest risk of mutation? Who's at the highest risk of developing breast cancer, even if their risk of mutation is not high? Now, in order to call out the highest risk individuals, we need to understand the risk factors for breast cancer. And those risk factors can be categorized as hereditary factors, hormonal factors, and pathologic factors. And we need to think of these three different areas in terms of how do we identify which patients are at what risk and need what management. This is a relatively complete list here in terms of what do you need in terms of hereditary factors. So who has had cancer of the breast or ovary in the family? What age were they diagnosed? Is there male breast cancer in the family? What's the relationship of each relative to the individual? What are the ages of relatives without cancer, etc.? On the hormonal side, height, BMI, Paris versus nulliparous, age first live birth. On the pathologic side, number of biopsies, history of atypical hyperplasia, LCIS, tumor markers of cancer. So we need to think about all of these factors for each person in the family and then put that together in order to put together a level of risk for the individual, determine what their management strategy needs to be, determine whether they need genetic testing or not, determine if they need MRI or not, etc. So how do you do that? Well, there are three basic ways of looking at this. One is to eyeball the information, take the information down on paper, think about it, look at it, and try to figure out what's going on. Another approach is the use of models, calculations that will calculate the numerical risk for each individual, or the use of guidelines, taking examples of high-risk individuals and seeing if your patient happens to fit that example. So I'll walk through that today, looking at eyeballing first. Many of us receive a sheet of paper like this from our patient after they're out in the waiting room with their clipboard. It tells you who in the family's had cancer, what their relationship is, what their age is. We try to remember this information, put it together with ethnicity or religious background, history of genetic testing, other risk factors, and then try in our head to put together even a mental pedigree about what these people look like, and does this group fit that there are multiple relatives affected, that there's young age at diagnosis, that there's multiple primary cancers in one individual, or that there are unusual cancers. And if we look at this piece of paper and we remember the criteria and we put it all together, we might identify a patient who needs to see a high-risk clinic. Unfortunately, this is why we see so few patients getting into the high-risk program, because we continue to try to do this in our heads, and it's no longer something that we can do very effectively mentally. So an alternative to that is using guidelines, and the NCCN is probably the premier group for making these types of guidelines. These are a set of guidelines, which I would call guidelines by example, of patients who might need genetic testing. Well, the problem with these types of guidelines is they are very difficult to read. In addition, what you've done here is had a group of experts sit in a room and come up with examples of people that they might consider testing for. So on the one hand, hard to read. On the second hand, hard to remember. On the third, not very specific. If you take the first one in the group, that any patient diagnosed under the age of 45 should have genetic testing. Doesn't sound unreasonable. On the other hand, suppose you're in your office and a 90-year-old woman walks in to see you and she says, I had breast cancer when I was 44 years old. None of my relatives have cancer. None of my descendants have had cancer. Should you test her? Well, according to NCCN, the answer is yes. And yet the yield on that would be extremely low. So we have to kind of think about this use of testing by example, because I don't think it's a very effective way of doing things in the computer age, though certainly it was a way to do things when we did not have computers. Alternatively, there are guidelines by tools. There are tools out there that can give you a risk of having a genetic mutation, such as the Ontario Family History Assessment Tool, the Manchester Scoring System, Referral Screening Tool, etc. And the U.S. Preventive Services Task Force says that BRCA testing should be considered if you're positive by one of these tools. Well, the first thing is that you would have to run this tool for every member in your practice. But the second thing, if you start thinking about other genetic syndromes, such as melanoma, such as colon cancer, prostate cancer, etc., you would have to have a tool for every different type of cancer, and potentially your patient would be filling out 6, 7, 10 tools in the waiting room every time you see them. You'd have to score these 6, 7, 10 different tools when you see the patient. So the idea of doing it by a single tool for a single problem is also not very effective over time. NCCN for colon has moved away from guideline by example and moved to guidelines by models. And rather than giving a whole list of examples of family constellations that might mean that a family needs mutation testing, they just say consider testing individuals over 5% risk on one of the following mutation models, MMR-Pro, PREM, or MMR-Predict. So this is another approach to start using models to identify the risk of mutation and then setting guidelines as to what level of risk would be appropriate in order to consider testing for an individual. The NCCN picked 5% for the colon cancer genetic testing threshold. Other people have picked 10%. I think probably moving towards 5% would not be an unreasonable approach for all cancers, and this guideline by models might be a reasonable way to go. Now, NCCN and American Cancer Society have also chosen to use guidelines by models for MRI screening. Both have said that if your risk of breast cancer in your lifetime is over 20%, then you should consider doing an MRI of that individual. They accept 3 models, Tyrer-Cuzick, BRCA, and Klaus. NCCN also accepts a 4th model, Boadicea, one that's very common in the UK, though not as commonly used in this country. But this is a way to determine who needs an MRI by determining what patients are over a 20% lifetime risk based on one of the models. And that brings us, of course, to the models. There are 5 basic well-known models used in this country. Again, Boadicea is also used in the UK, but not as commonly in this country. So let's kind of look at these models: Myriad, Klaus, Gale, BRCA-Pro, Tyrer-Cuzick. Tyrer-Cuzick has recently had an update, so we have Tyrer-Cuzick 6, which was the former version, and Tyrer-Cuzick 7, which is the more recent version of that model. Tyrer-Cuzick 7 is also now, Tyrer-Cuzick is also now coming out with a new model that includes breast density. They've just published on this particular model, but has not yet been validated and is not yet available for general use, but should be coming available relatively quickly. Now, let's look at these models in terms of what they look at and what they do. The Myriad model, or the Frank model, only tells you the risk of mutation and only tells you who might be eligible for genetic testing. Klaus and Gale only tell you the risk of breast cancer over time. They do not tell you the risk of having a mutation. Klaus can be effective for determining who needs chemoprevention, who needs an MRI, or who needs personalized screening. Gale is useful more for chemoprevention or personalized screening. It should not be used to determine who needs an MRI. The American Cancer Society and the NCCN have both said Gale is ineffective in identifying high-risk individuals for hereditary reasons, and therefore should not be used to determine who needs an MRI. BRCA and tyrosine give you both a risk of mutation and a risk of breast cancer over time, and both of them are useful to determine who needs genetic testing, who needs chemoprevention, who needs an MRI, who needs personalized screening. BRCA is limited mostly to hereditary factors, whereas tyrosine looks at hereditary, hormonal, and pathologic factors. So each of these models has their own strengths and weaknesses. And for this individual, this is your risk of breast cancer over time by each of the individual models. And you see for this particular patient, at the lowest level of risk for the individual comes from their Gale score. And the reason for that is that this patient has no first-degree relatives or only has one first-degree relative with breast cancer. So very low level of risk. On the other hand, Klaus is a little bit higher, but doesn't pick up the fact that there's also bilateral breast cancer in the family 2 generations away. BRCA only looks at the hereditary factors, and tyrosine looks at the hereditary factors plus the hormonal factors and the pathologic factors and gives a very high level of risk. So when you look at this, you start to understand or realize that each of the models is going to give you a different number based on what factors are important in that particular individual. If you're dealing with a family where there's both hormonal and hereditary factors, tyrosine is going to pick it up, whereas Gale will not pick it up as well. So you're going to find that different models give different levels of risk. Now, what I've gotten to be one of my favorite quotes is a quote from Box, who said that all models are wrong, and I think he's completely correct, but followed up with, but some are useful. And I think what's important to think about when you're looking at risk models for breast cancer is that while the models are all wrong, none of them is going to give you the exact correct answer. They have utility, and picking the right model for the right situation can help you manage the patient better, even though the model is not perfect. Now, as an example, let's look at BRCA. BRCA would look at this family, would identify who's had breast cancer, what age they were diagnosed, who's had ovarian cancer, what age they were diagnosed, how many males in the family have had cancer, what age diagnosed, what's the degree of relative, what the ages of the unaffected relatives. And by putting that together, they can give you the risk of mutation not just for the patient herself, but then also for each of her relatives. So you can see here the risk of mutation within the family. You can identify who the woman at highest risk of having a mutation would be an ideal candidate for doing genetic testing. But it would give you a tremendous amount of information, not just about your patient, but about her entire family. Now, Dave Hughes did a very nice study comparing BRCA against experts in the field. And he took 148 pedigrees, ran those pedigrees through BRCA, and then also showed them to a group of nurse practitioners and genetic counselors who were experts in genetics, and identified what the difference was in how these people predicted risk over time. And what you'll see here from the ROC curve, the best curve was a genetic counselor, the second best curve was BRCA, and all the other curves are a little bit lower, a little bit weaker return on, area under the curve for the ROC curve. This doesn't mean that BRCA was better than the other genetic counselors. What it means in general within statistical limits is that BRCA and the genetic counselors and the nurse practitioners all did about the same. Now, this does not mean BRCA can replace a nurse practitioner or replace the genetic counselor. But what it means is that if you're given a given family history and you're asked to interpret that family history, you're going to find pretty good results just using the model as well as using an expert in the field. Now, why that's important is that you cannot have a nurse practitioner or genetic counselor see every single patient walking through a breast center, walking through a mammography center, because we just don't have the manpower to do that. But you can run risk models on every single patient. So this idea that we can run a risk model on every patient coming through breast imaging, every patient coming through breast surgery, every patient coming through medical oncology should allow us to get a good first pass at who the highest risk individuals are, get those higher risk individuals off to the genetic counselor or nurse practitioner, and then have those people be managed by that group because they're getting to where they need to be to get proper management. So think about what happens in breast imaging or what happens in medical oncology as a screening family history to get the patient over to the counselors who can do it more thoroughly. Now, the way we approach this is the risk apps approach is we let the patient enter her own data. So we give the patient a tablet PC or an iPad or let her do this from home through a website. The patient enters her family history through the computer. The computer runs the risk calculations and runs the various guidelines trying to identify which patients might be eligible for genetic testing or an MRI. Tells the physician which patients look like they're elevated risk, either needing MRI or genetic consultation or both, and then helping the doctor get those patients off for those additional studies or those additional consultations by helping them track those patients, write letters, send letters, have particular lists put together, but helping the doc to do more. So at the first part of this, we don't need to have someone sitting in a room with the patient taking the entire family history. The patient can enter that herself. We don't need the doctor to be able to do risk calculations in their head. The computer can do that. But when you display that to the doc in an intuitive manner and help the doc to make the proper consultation, we feel that this is what we called before intelligence amplification, the ability to take the strength of the computer, take the strength of the human, and get the patients to the proper area for consultation. So whereas in the old days we might look for relief from above, someone might help us get to beyond where we are as human beings, we'd like to think that the future could potentially be clinical decision support. Let humans be able to do what they do best, let computers do what they do best, and overall produce a more effective management of individual patients. Now, on that note, what I'd like to do is show you briefly what we do with Hughes Risk Apps, and then once we've done that, I can then go on, get rid of these changes here, and answer questions. So this is our tablet PC. This is what the patient would see either on an iPad and on the internet or on a kiosk, which would then bring up the list of patients coming in for today. We'll pick the short breast survey, which is a very scaled down survey that can be done in the context of a waiting area without causing too much disruption in the schedule. The patient is handed the tablet at this point. If she speaks Spanish, it could be done in Spanish. If she speaks Brazilian Portuguese, we can use that. No matter what language it's done in, it prints out in English. The patient does this themselves. You can see that the buttons are big, the font is large, the questions are simple, and patients in general do this very easily. There's branching logic, so if you say no to your periods, it then says, what age did you stop? If you say yes, you're still having periods, it doesn't ask you when they stopped. If you say no pregnancies, it doesn't say how many children have you had. So the questions are relative to the specifics of that individual patient. If we said yes to biopsies, it'll ask about atypia. The patient may remember that. We'll say yes to radiation, no to birth control pills, no to fertility drugs. Say this patient's Caucasian, that she is not Hispanic, that she's not Jewish. She herself has had cancer. So we want to know what cancer she's had. She had a lymphoma when she was 15. Her relatives have had cancer, so it wants to know which relatives, starting with the immediate family. If you choose a sister, it might want to know if there's more than one sister with cancer. And we'll say that the first sister had a melanoma, and she was 23. The second sister had ovarian, and she was 45. Goes on to the mother's family. There's only one mother, could be more than one maternal aunt. The mother had ovarian as well, and she was 46. And the aunt had breast cancer. And with her breast cancer, it wants to know if it's bilateral. And if bilateral, how old for the first, and then how old for the second. Goes on to the father's side of the family, and if you pick a male, you see prostate cancer rather than cervical ovary uterus. So he's 89. No genetic testing in this family. Put in the email address. Now, if the patient hit the next button, the next screen would say, thanks very much, you're done, bring it back to the desk. When I hit the next button, you'll see the risk calculations being done. The patient would not see this. With the patient having entered her data, we run BRCA Pro, Cloud Scale, Myriad, Thyroid-Cusic, MMR Pro, Prem, and CC-RAT. And immediately get a printout that would go to the clinician that would tell the doc what needs to be done. So the patient has entered her own data. The computers run all the risk calculations. They've taken those risk calculations and then made a suggestion as to how to manage this particular patient. So at the top of the screen, you see that, or at the top of the printout, this patient is suggested for genetic testing for breast ovarian syndrome, because she's over a 10% risk of mutation. That's a threshold we happen to choose, but that's negotiable. She's eligible for MRI screening. She's over a 20% lifetime risk by BRCA Pro or Thyroid-Cusic. And she also needs an MRI because she's had chest wall radiation under the age of 30. The printout also includes all the information the patient has entered, shows the family history as a table, shows all the risk calculations in case you want to know specifically what each model has shown in terms of mutation risk, 5-year risk, lifetime risk, etc., and draws a pedigree for the individual as well. What this system also does then is generates a letter to the referring doctor saying that this person meets the criteria for MRI, and here's why they meet the criteria for MRI. Here are some references, and then this is what you would put in your letter of medical necessity when you email the insurance company, because this will help them to get certified for compensation, because they're giving the right information to the medical director of the insurance company. And prints out smoking cessation information because the patient's a smoker. Now, you might look at this and say, well, a human being can do all this, and the answer is that a highly trained human being could do all this, that they then could generate all these letters. But in terms of efficiency, lay in the computer, collect the data, run the calculations, generate the letters, is, from my point of view, what computers are supposed to be doing. So at that point, I'll say thanks very much and turn it back over to Kristen.
Thanks, Dr. Hughes. At this time, if you guys have any questions, please go ahead and type them out in your question bar in the GoToWebinar panel. I'm going to go ahead and start asking Dr. Hughes the questions that have been submitted already. So Dr. Hughes, the first one is, do you think risk assessment will continue to provide downstream revenue for breast MRI, or will we see a change in insurance reimbursement to a different breast imaging modality in the future?
So the current guidelines for MRI by both NCCN, the American Cancer Society, and also for the American College of Radiology, are to do MRI for anyone with a 20% or greater lifetime risk of breast cancer. I do not see that changing in the next 2 to 3 years, just because these guideline generating bodies are extremely slow moving, if not glacial, in their approach. On the other hand, other modalities are coming down the pike: whole breast ultrasound, gamma breast imaging, PET scanning of the breast, those are tomosynthesis. These other things are becoming available, but I don't see them becoming part of the guidelines in the near-term future, but certainly important over time. So I think the quick answer is that I don't see MRI revenue going away in the next few years, but eventually, certainly things will change as we get more imaging modalities available.
All right. What is your position on the adequacy of informed consent if NGS is used for multiple hereditary abnormalities? Myriad is promoting its NGS panel as a panacea, but we worry that its patients will be blindsided by unexpected results or by results without accepted follow-up recommendations.
I think this is a very interesting question. So we've moved into panel testing, and we're not going to be going back. So we have the ability now to do 25 gene panels for the price we used to do just BRCA 1 and 2. There is at least one genetic testing company that's running a 200 gene panel for less than the price of BRCA 1 or 2. It's hard for me to, as a physician, to not want as much information as I can possibly get. On the other hand, the concern about the patient not knowing what they're getting into is certainly a valid one. Yeah, on the one hand, when I gave a lecture recently, somebody in the audience had said, "Isn't the cart before the horse?" That we're doing all these tests and we don't always know what to do with the answers, and patients aren't always ready for the answers. And my response was, "The horse is out of the barn. We're doing this. It ain't going away." So I think we're there. This is the era we're living in. I think that it's best to inform patients as best you can. But in my own dealings with patients, what I tend to say to them is, here's what BRCA1 are all about. This is what we think you probably have. However, we're going to be testing these other 23 genes as well. And we may find that you have a mutation in some other gene. And if I find that, we're going to then deal with what risks are involved with that other gene. I don't see another way around it. I don't see a way for us to counsel about 25 different syndromes simultaneously. The patient will never understand everything we're telling them. And on the other hand, I'm not interested in withholding information from the patient. If I get a result, I'm going to have to tell them that result and try to make it as easy for them to understand as I possibly can. So I understand the problem. I feel the pain of the questioner, but we're going to have to learn how to deal with it, and we're going to have to learn some new models as to how we go about taking care of these patients.
Thank you. How does this program work with cancer centers that already have a genetic testing and counseling program? For those that do not, ethically, can it be used without having a genetic counselor available? How can it be used to support the ACOS COC standard 2.3 for risk assessment and genetic counseling?
So in answer to the first question, the part of the program that I showed you is how do we identify patients who are at elevated risk. And from my point of view, this is a perfect program for a hospital that already has a counselor or a risk assessment program in place, because it's going to identify the patients that are currently being missed and getting more patients to the counselor to be taken care of. As far as the second two parts of the question, I would jump to the American College of Surgeons standards, which say that a professional, a physician, nurse practitioner, genetic counselor who's well-versed in genetics is allowed to do genetic testing and genetic counseling. So I would say that what the program will do, and the second part of this program is one part of our software, is one that helps counselors take care of patients better by tracking their patients, helping to know who needs genetic testing, helping to track those results, helping to track VUSs and other things, that this software can be extremely helpful to a genetic counselor, to a nurse practitioner, to a physician who's well-versed in genetics to help them take better care of their patients. So from that point of view, I find it quite ethical.
Okay. What would be the cost of the program and the startup fees? And how would they gain access to it?
So you'll all have my email address at the end of the webinar. Please feel free to email me. I am an academician. I've recently founded a company, Hughes Risk Apps, to distribute the software because Harvard was not interested in distributing the software in any meaningful way. part of starting a company is hiring a CEO, and one of the first things my CEO told me to do is never discuss price. So when if you're interested, please go to our website. Please contact us, email me. We need to look at your specific situation. How many counselors there are, how many patients are you seeing, how many sites are you dealing with, how many different databases do you need, and that'll help put together a price for each individual. But I would say we're competitive.
Okay. This one is a multi-parter. So A, discuss risk management for women with moderate lifetime risk for breast cancer. B, discuss genetic testing in unaffected individuals. And C, discuss use of MRI in high-risk surveillance.
So moderate risk is somewhat in the eye of the beholder, and it's a very interesting question. So what are the things we have available? We have genetic testing, prophylactic surgery, MRI, intensive screening. When we look at the way we would look at this, the way I would look at this is the first thing is, does this patient need genetic testing? If they need genetic testing, get them to a genetic counselor, get them to a risk assessment program, get them tested, and then that program would decide what to do next for the individual depending on what the test results were. Then you get the patients who don't meet the criteria for genetic testing. And among those patients, who are the ones who meet the criteria for MRI, the 20% or greater lifetime risk? Those patients, you definitely want to get them in for their MRI if they can tolerate it. If not, get them in for ultrasound or gamma imaging, PET, something else. And then that leaves you with the patients under 20% lifetime risk and also do not need genetic testing. So the group under 20%, we think of the moderate risk as 15 to 20% lifetime risk. I'm not sure if that's correct, but that's what kind of people are starting to gravitate to. So for that 15 to 20%, we don't have good recommendations as to what to do. I would certainly look at that person very carefully in terms of the need for chemo prevention. And I would say that's also true for those over 20% lifetime risk. Does this patient need chemo prevention? They definitely need a yearly mammography. Now, if they're under 40, you have to kind of look at their level of risk relative to their age. And then for the patients who fit into that 15 to 20% category, you might then look at breast density and say those who have the densest breast might benefit from whole breast ultrasound or gamma imaging or PET, whereas those that have lower breast density might be fine with mammography. So I think for the moderate risk patients, do they qualify for chemo prevention? We definitely make sure they don't qualify for MRI or genetic testing because that's certainly high risk. But for the moderate risk, do they qualify for chemo prevention? Should they be getting other imaging modalities besides mammography? And then which modalities are them? And should we follow them more carefully? I think the moderate risk are a group we have a real problem with right now. In terms of unaffected patients, I really try to test affected individuals first, so we know the family-specific mutation. There are times when that's not possible. So for the patient where there is no family member who is testable and the patient meets the criteria for genetic testing, I will do genetic testing on them. But if they come back negative, I'm very careful to tell them that I can't completely rule out a genetic problem because we don't have the information about their family mutation. But sometimes you just have no choice. And getting back to MRI, I would just say that the current recommendations, 20% or greater lifetime risk via an MRI. That's kind of what the societies are all saying, and I tend to go along with that.
All right, this one is about your presentation. You had a table, the prevalence and penetrance. It was about breast at the beginning. They're wondering where this paper is from, or where the table came from.
That's an excellent question, and I was looking at that slide and thinking the same thing myself. Kristen, if you don't mind emailing me, I will track down that reference and get it back out to the group. I apologize. I think I ended up taking that off the slide or losing it when I was doing some editing, but I will definitely track that down.
I sure can.
Okay.
Another one is the app or program used to calculate risk available.
Yes. So if I don't have the reference, I apologize. Yes, if you go, I'm going to go here. Sorry. Get to that. If you go to HughesRiskApps.com, you can read more about purchasing the software and installing it. But if you go to Express Entry here, on Express Entry, sorry, I got an email coming through there. On Express Entry, you put in your email address, start a new patient, put in family history, very simple, and this is called Express Entry for exactly the reason that it's very simplified. Not a whole lot of data you can put in. You can't put genetic testing results in, but at least you can put this much. Put in the weight, the height. She won't be 7 foot tall. Let's make her 5. 4. 0 pregnancies. 0 biopsies. Not Jewish. 11. No. American, and no. And so with a very small number of data entry points, you can run all the risk models that I've showed you today. So this shows you the risk of mutation by BRCA Pro, Myriad, Thyroid 266, N7. Shows you the risk of breast cancer at 5 years in lifetime. Shows you the risk of ovarian cancer 5 years in lifetime. Draws you your pedigree, and then shows you the information that was entered. So the Express site is freely available. Feel free to use it and run the risk models quickly. And then alternatively, you can install the software to run the models.
Awesome. Well, thank you, Dr. Hughes, for that awesome presentation, and thank you, everybody, for attending today. We've reached our time limit, and we definitely have a lot more questions that I will get with Dr. Hughes on to answer, and we will send out an email with all of those answers. The webinar was recorded today, and you will be getting a copy of it, as well as a copy of Dr. Hughes' presentation within the next 24 to 48 hours. You'll also be able to access the recording on our website at chordatahealth.com. And if you think of any additional questions, feel free to email either myself, and that's on the response to the webinar registration, or Dr. Hughes with his contact information here, and we'll make sure to get your questions answered. So thank you guys very much. We really appreciate your attendance, and thank you, Dr. Hughes, again for doing that awesome presentation.
Thank you. We'll talk to you soon. Bye-bye.